Greetings, everyone, and welcome to the IFAM seminar series at Northwestern University Feinberg School of Medicine. My name is Renad Betis, and I'm the chair of the Department of Medical Social Sciences, and I'm excited to be here to be able to do the introduction. I'd just like to take a moment to remind you all that we will not be monitoring chat during this seminar as indicated in the webinar chat. We do want to encourage you, though, if you have questions for our speaker, to use the Q&A function at the bottom of the screen, and we'll do our best to answer them during the Q&A portion if time permits. I want to thank Andrew Nellis for all of his work coordinating the seminar, Dr. Ron Ackerman, who's the Institute Director, and Dr. Sarah Becker in the Center for Dissemination and Implementation Science that's leading the bringing together of our robust implementation science community here at Feinberg. So without further ado, I'm really excited to be introducing a colleague, Dr. Alicia DeRogers. She's an assistant professor of psychiatry and human behavior at Brown University with a secondary appointment in social and behavioral sciences. She's also a faculty member in the Brown Research on Implementation and Dissemination to Guide Evidence Use, or the BRIDGE program. I've had the fortunate opportunity to see her present before, and you are going to be blown away. Her research focuses on implementation science in the global mental health context, and she serves as PI of an NIMH-funded R01 hybrid implementation effectiveness trial to implement an evidence-based mental health intervention within secondary schools in Sierra Leone, and she also has a Hilton Foundation Award. So without further ado, Dr. DeRogers, please take it away.
Thank you so much for that lovely introduction, Renad. And I'm very excited to be here and have the opportunity to talk and present at the seminar today. So what I'm hoping to really address today is why implementation science matters in low resource and conflict affected settings globally. So I'll talk a little bit about the global mental health treatment gap and how implementation science can play a role in addressing this gap. And then I'll present case studies of work in Sierra Leone and also in Colombia. So why do we need to address mental health disorders? Well, they're really common across the globe. Data from 2019 show that approximately 15% of the population had one or more mental health disorders. And we also know that mental health disorders are increasingly contributing to the global burden of disease. And unfortunately, expenses or expenditures towards mental health and mental illness are really low compared to other types of disorders or conditions, particularly in comparison to infectious diseases. And the situation is typically worse in most low and middle income countries where the government expenditure per capita on mental health is I might say alarmingly low compared to high income countries, especially in comparison to the prevalence of mental health disorders. And then to further add to that situation, there are a limited number of mental health professionals in most low and middle income countries, particularly if you kind of look at this chart in the African and Southeast Asian regions. So this sets up a situation where there's a high need for mental health services. There is a low sort of priority among governments to provide support financially or in other ways for mental health services. And there's a limited or lack of mental health professionals. So we really need some innovative strategies to try to address this mental health gap that can be sustainable in these types of settings. And this is where implementation science can really play a significant role, because the goal of implementation science is to bridge this gap between research and practice. And it's really important, really right from the beginning, to be thinking about implementation science when considering research or even just an impact evaluation, or trying to implement an evidence-based intervention. Because we've all probably heard how long it takes to actually translate research into real-world practice, and then it's often a poor fit for those consumers, patients, providers, and users at the end of it. So it's really important to be thinking about who's going to be delivering the intervention, what's the ultimate fit with the patient population, is it going to be acceptable and feasible to this population, what kind of strategies can support training and supervision, and what types of designs might help us answer implementation-related research questions. So all this really needs to be thought about right from the beginning. And then there are a number of theories, models, and frameworks that can help us in the implementation process. And some of you might be familiar with some of these already, but just in case, a quick overview I think can be helpful. So there are different types of theories to help with implementation research. We have explanatory theories that can help us understand or explain what's influencing implementation science outcomes. We have theories that help guide translation of research into practice or implementation process models. And then we have models that are more about evaluating implementation outcomes. So in most of the work that I've done, I have applied the EPIS model, which is an implementation process model. And the EPIS model involves 4 phases: exploration, preparation, implementation, and sustainment, which can help guide and organize the implementation process. And then through all of these different phases, there are factors in the inner context of an organization. So these might be things like leadership, staffing processes, the types of quality monitoring that are happening. And then there are factors in the outer context. These could be things like legislation, policies, the socio-political context, funding, contracts, and these can influence implementation during any of these phases. And then you have bridging factors like community academic partnerships and innovation factors. This could be something like applying user-centered design to increase innovation fit that can help connect the inner and outer context. And then in terms of an evaluation framework, so I've layered different types of frameworks into the research, which is something many people do. There are also other frameworks that are more comprehensive and can kind of fit all needs in one. But the framework for evaluation that I've used most often is Enola Proctor's model, which distinguishes between implementation level outcomes, service level outcomes, and then client outcomes. And so the focus is really on what are the important implementation outcomes that can help us understand effectiveness of implementation. These are things like acceptability, adoption, cost, feasibility, fidelity, and sustainability. And then there are also different types of designs that can help answer research questions in implementation science. So some of the most commonly used designs are the hybrid designs. And on the continuum from clinical effectiveness to research, to implementation research effectiveness, we have 3 different types of designs. And so just briefly, a hybrid type 1 focuses mostly on determining clinical effectiveness of an intervention, but there's also some secondary goals of looking at maybe the implementation context, exploring barriers and facilitators to implementation. And then in a hybrid type 2, there's more of an equal emphasis on understanding the effectiveness of a clinical intervention and the implementation effectiveness. And then in a type 3, you've already had sufficient evidence from prior trials to determine clinical effectiveness. And what you're really looking at is the impact of an implementation strategy and the implementation outcomes. And you might gather some data or collect some data on a few clinical outcomes, but the goal is really to answer implementation research questions and evaluate implementation research strategy. So with that little bit of context around implementation science and global mental health in terms of the need to improve service access and address this gap, I'm going to move on to presenting some work in Sierra Leone. So for anyone who's not familiar, Sierra Leone is a small nation on the west coast of Africa. It's bordered by Guinea and Liberia. And it's a nation that's been plagued by a long history of compounded adversity. There's a population of just under 7 million. The median age is 19. For quite a while, Sierra Leone has ranked the third highest in the world for maternal mortality rates. It's also been ranking quite low on the Human Development Index. And in terms of its history of adversity, Sierra Leone experienced an 11-year civil war that resulted in massive population displacement and the recruitment of a large number of children into armed groups. And after the Civil War concluded and there were peace agreements and the country was in a more positive rebuilding phase, they were struck with a very devastating Ebola outbreak, which really put an extreme strain on their healthcare system because the deaths were disproportionately concentrated among healthcare workers. And then shortly thereafter, in 2017, this picture shows a mudslide that Sierra Leone experienced, which caused further trauma to the population and a number of deaths. Sierra Leone has been experiencing what's referred to as a youth bulge. As I mentioned, the median age is 19. Approximately 60% of the population is under age 25. And unfortunately, literacy levels are quite low in the population, especially in the rural areas. The rates of enrollment in senior secondary schools are low. And of those enrolled, completion rates are estimated at only about 43%. So a large proportion of the population is young, under age 25, and they're really struggling economically, educationally, with other types of life opportunities. So addressing mental health needs of this population is really critical. And then in terms of Sierra Leone's healthcare infrastructure, quite unfortunately, for a nation of just about 7 million people, there are only 2 psychiatrists. I've been told that there are 6 or 7 psychiatry residents in training right now, so hopefully they'll stay. But for quite a while, there have only been 2 psychiatrists. There are approximately 17 mental health nurses that were trained on the MH-GAP. So the needs of the community, of the nation really, in terms of health and mental health, are supported by this foundation of community health workers, which serve the communities in which they reside. There is some training, but there aren't really formal education requirements other than a basic literacy level and completing like what we would think of as a 7th grade level of education or junior secondary school there. So with this background, we can see that there are a number of implementation problems that are contributing to the mental health treatment gap in Sierra Leone. We have a lack of trained professionals. We have some limited delivery settings, difficulty accessing any services that might be available, and there's a very limited amount of funding going towards any type of mental health or training more professionals in mental health services. So what's the strategy? One of the key strategies that I've explored and the people I've worked with have explored are alternative delivery platforms for providing evidence-based mental health interventions for youth. And a lot of these different delivery settings have also leveraged task sharing approaches and training non-specialists to provide mental health services. So the intervention that I'll talk mostly about today is the Youth Readiness Intervention. This intervention was developed by Dr. Teresa Battencourt in 2011. We refer to it as the YRI. And it was developed really to address the unmet mental health needs of youth who had been affected by war or returning after experiencing war and being involved in the armed conflict. The intervention was culturally developed. It includes a lot of parables and metaphors, and community-based participatory research methods were used quite heavily in developing it. It's also a transdiagnostic intervention that integrates core components from cognitive, behavioral, and interpersonal therapies. It also includes mindfulness-based components. And it's a group model that can be delivered by a number of different types of lay health workers or non-specialist health workers, and it includes 12 sessions. These tend to be delivered weekly or bi-weekly, but there's some other delivery formats we've explored recently as well. And the first clinical trial of the YRI was conducted in an alternative education setting. And the findings of this trial showed that youth who participated in the YRI demonstrated significant improvements in emotion regulation, pro-social behaviors, and day-to-day functioning than youth in the waitlisted control group. And I think notably, the youth who participated in the YRI were 6 times more likely to persist in school. So this sort of sets up the hypothesis that improving some of these psychosocial skills, mental health, emotion regulation can potentially help youth achieve better educational and academic outcomes, though we did not specifically test them. So now there's an evidence-based intervention. We have good data showing that it's effective. So the next steps were really to think about how can we expand the reach of this intervention and increase service access. And this was the focus of a project called Youth Forward. And the Youth Forward study partnered with, this was a study led by Boston College, but also provides some important backgrounds that my work has been building off of. So the Youth Forward study focused on partnering with a German development company called GIZ that was planning to implement entrepreneurship training and employment training across 3 rural districts in Sierra Leone. And they wanted to incorporate a psychosocial competency training component into their programming. So here we were with this evidence-based mental health intervention. It had already been tested. It was a really good fit and opportunity to provide an evidence-based service to fill the psychosocial competency component of GIZ's programming. And so we were able to feasibly and acceptably implement and scale out this combined program across these 3 rural districts, which you can see are the far east of Sierra Leone, these highlighted districts, Kono, Koinadugu, and Kailaun. And so even though the scale out was successful, GIZ implemented their program, and then the program wasn't continuing after that. So the scale out and increasing access worked, but the sustainability was still kind of an issue, or there were still implementation problems related to the ultimate sustainability. So there was some further opportunity to think about what else or what other settings could the YRI be implemented in, and what other strategies, what other implementation strategies could be tested to increase adoption and sustainment. And so this has been more of the focus of one of the projects that I'm currently leading in Sierra Leone, that is leveraging secondary school settings to serve as delivery platforms for the YRI and training teachers as delivery agents. And a big component of this also is to test digital strategies to support training and supervision of teachers delivering the intervention. So this is a hybrid type 3 implementation effectiveness trial, and it's a type 3 trial because the YRI has already demonstrated evidence as a clinical intervention for effectiveness. And so the focus was really to look into testing and implementation strategy and understanding what factors might influence adoption and sustainment of the YRI within school settings. So the first aim, actually all the aims map onto different phases of the EPIS model. So the EPIS model did guide, or has been guiding, the implementation of the study aims. So the first aim was to look at barriers and facilitators to the YRI, which would be supported by an mHealth app in Sierra Leone schools, and then also to apply user-centered design methods for the supervision app development. In terms of the implementation aims, the goals are to examine feasibility, acceptability, and fidelity to the YRI delivered by teachers receiving a mobile phone-based supervision. This is the one that has the app on the phone versus like a standard in-person supervision. And then to compare the clinical effectiveness of the YRI delivered by teachers in these different conditions. And this is designed as a non-inferiority trial. We don't really expect to see different clinical effectiveness outcomes, but we want to test it to understand it and go ahead and ask that research question. And then the last aim is really to understand sustainment. So we'll be investigating mechanisms, or implementation science language would call them determinants, of YRI adoption and sustainment within schools. We've hypothesized that organizational climate and readiness to change could influence adoption and sustainment. And then a final goal will be to do an economic analysis. So to carry out aim 1 with the needs assessment, we are developing an implementation blueprint. And this draws from the work of Kara Lewis. And also I know Kelly Scott, who is there at Northwestern with you all, has played a big role in carrying out this work. So the idea with the implementation blueprint is to investigate barriers and facilitators by really involving the key stakeholders that you're working with. So in our case, it was teachers, principals, and Ministry of Education officials. So the first step is to conduct a needs assessment, analyze needs assessment data to identify implementation barriers, then select the implementation strategies that you think might address those barriers. And these can be drawn from the ERIC list of implementation strategies. And then you convene your stakeholders to review the barriers and facilitators, and also the different strategies, and rank them to try to identify trade-offs and priorities. And then through that work, you can develop or co-create the implementation blueprint. And then for our app development process, we have applied a 5-phase user-centered design approach. And the goal is also to integrate WhatsApp within this app, because it's a very widely used chat and messaging platform in Sierra Leone. And we think the chat features and communication are critical for supportive supervision and communication. So in this 5-phase user-centered design approach, the first phase is problem analysis. Again, we're engaging those key stakeholders right from the beginning, or sometimes these are referred to as primary end users in design thinking. And really the goal is to understand what are their needs, wants, desires, challenges in terms of the app, not broadly speaking, but in terms of the app, and then to incorporate that feedback into design of an initial prototype. After that first prototype is designed, the next step is to engage in several rounds of user interface, user experience testing with primary end users. And then this feedback, again, from the user testing phases, can inform and be integrated into a final prototype that will be implemented and then evaluated in the trial. And in terms of study design, this is a cluster randomized study design where schools are randomized to one of 3 study conditions. We have schools receiving YRI plus mobile supervision, YRI plus standard in-person supervision, and then control schools, which are mainly needed for our economic analysis. And then in our intervention schools, we have a total of 160 teachers. So there'll be 80 teachers in each of the intervention schools delivering the YRI. And data will be collected at baseline, which we're in the process of doing that right now, post the YRI implementation, and then at 12-month follow-up. And we'll be using mixed methods data collection approaches. And then just briefly, thinking back to that evaluation framework in terms of our implementation outcomes, data will be collected at the level of youth, teachers, and principals, and the primary focus is going to be on the implementation level outcomes, drawing from Proctor's framework, with the addition to organizational climate and readiness to change, which we're going to examine as mechanisms or determinants of sustainment and adoption. So where are we at now with this study progress? So in terms of app development, we've completed problem analysis. We convened 2 focus group discussions with our primary end users, which are teachers and supervisors. And then insights from the focus group discussions were incorporated into the design of unique user journeys. And I know you can't really see the words on this second photo, but it just gives you an idea of how the design thinking process kind of visualizes and storyboards, to inform what the feedback is from individual people during like a problem analysis phase. I think it's really kind of cool and interesting. So there was a prototype developed based on these user journeys and the feedback from the problem analysis phase. And then we've completed 2 rounds of user testing with our teachers and supervisors to get additional feedback on different functions and features of the prototype. And then this feedback was again incorporated into the final app, which we are ready to roll out in the trial now, which will be in the implementation and then evaluation phases of that 5-phase user-centered design model or process. And some of the key features of our app are that it works offline. It includes digitized fidelity monitoring tools and different types of chat features, including WhatsApp. So we want to encourage communication. We want to encourage data-driven supervision by having fidelity and competency checklists that both teachers and supervisors can complete after each YRI session or after supervisors are viewing a session. So there's a feature to record sessions in the app, and then they can be viewed later by a supervisor or even by the teachers if they want to review something that happened in the session. And then regarding our implementation blueprint progress, so we've conducted our needs assessment and analyzed the data from that needs assessment to identify our key barriers to adoption and sustainment of the YRI. And our findings were that the following barriers were ranked at the highest as key barriers. These included parent-teacher buy-in, teacher motivation, scheduling challenges, just like trying to find time during the day or after school for scheduling YRI sessions, limited resources, both human and financial, to support sustainment. Just the overall relevance of the YRI, was this going to be relevant to youth? And then waning interest. And I'll say some of these were already beginning to be addressed after collection of the needs assessment data without actual strategies or plans to do that. But so after we had completed this data analysis and we had our key barriers, we reconvened our stakeholders to review the findings and also to select implementation strategies that might address these barriers. So we sort of pared down the ERIC list to the strategies that would be the most relevant, and then talked with our stakeholders and engaged in a very low tech conjoint analysis where the stakeholders ranked barriers on high versus low feasibility and high versus low importance, and then the same thing with the implementation strategies. So the next phase is really coming back to think about, okay, how do we now develop this blueprint? And lastly, in terms of our progress and what stage we're at, we are currently preparing for launching YRI implementation in schools. We've recruited all of our schools and teachers. We've completed training with 160 teachers, which was actually quite a feat. And we are currently completing, we should by the end of the month, complete recruitment and enrollment of youth and all of our baseline data collection. So that concludes the examples from Sierra Leone. And the last case study example that I'll talk about is work in Colombia. Again, just to kind of orient everyone, Colombia is a country in South America on the northwest coast. And importantly, it shares this border with Venezuela. And as I'll talk about in my research, has accepted a high number of Venezuelan migrants and refugees into the country. Colombia is a very different context from Sierra Leone, but one thing they share is a history of adversity and conflict. Colombia experienced over 50 years of armed conflict, which involved recruitment of children, a large number, into armed groups. Colombia doesn't really recognize that children were forcibly recruited into armed groups at the current state, but it's widely known that this had happened. And even after the peace agreements in 2016, violence continues in many regions. There continues to be conflict. Approximately 9 million Colombian youth and families have been impacted by armed conflict and internal displacement, either directly or indirectly. And as I mentioned, Colombia has received a large proportion of Venezuelan migrants and refugees who have their own histories of either experiencing conflict or economic hardship or safety concerns, lack of healthcare needs, a lot of different types of problems, and then have also migrated to a new country and are trying to establish a life there. So there are many youth who are experiencing mental health challenges in Colombia, both Venezuelan migrant and Colombian youth, that have been related to this conflict and displacement. And all of these issues help or don't help, they get in the way of their economic and social development. There have been some policies Colombia has instituted to try to address these needs, but the policy to practice sort of process hasn't really shown that these services are accessible or even that they've been implemented. So for the most part, evidence-based mental health services for these types of vulnerable youth have really not been available. So again, there's a number of implementation problems that are contributing to a mental health treatment gap in Colombia for these vulnerable youth. There aren't enough trained professionals to deliver services, particularly in the neighborhoods or in more rural regions, where sometimes there's a higher concentration of displaced persons in the poorer neighborhoods surrounding cities. There's poor access to services. Again, as I mentioned, there's limitations with the policy to practice, kind of like pipeline in that process. And there's a lot of mistrust in services that are provided. So buy-in is low among youth and their families and anyone who might be considered a consumer of mental health services. So the implementation strategy here in the Colombian context has been to adapt the YRI for Venezuelan migrant and forcibly displaced Colombian youth, and then also to explore alternative delivery settings, again, that might increase accessibility. So scaling and adapting an evidence-based intervention can be one strategy to try to increase accessibility rather than developing a new intervention altogether in a more time-sensitive way. So this study was a hybrid type 1 implementation effectiveness trial because we're now bringing and adapting an evidence-based intervention to a new context, but it's never been tested there. So we really want to understand the clinical effectiveness of the YRI after it's been adapted for this new population. And then there'll be just some preliminary data collection on things like feasibility and acceptability that relate to implementation outcomes or planning for a later implementation trial. The other aims of the project are to investigate feasibility, acceptability, and fidelity of the YRI, which we'll be integrating within an entrepreneurship training program among displaced Colombian and Venezuelan migrant youth, and then to investigate the effects of the YRI integrated within this entrepreneurship training program on both mental health and economic outcomes. And this is just a 2-arm trial where we're comparing intervention youth to waitlisted control youth. For the adaptation process, we've used ADAPT-IT, which draws from community-based participatory research and involves a number of phases to guide the adaptation process. The first phase involves a needs assessment to understand the needs of your target audience. So we engaged with conflict-affected youth and community leaders in a community that was part of Bogota in Colombia. And then from that data, after analyzing the data, we tried to start planning how we would adapt the YRI for Colombian youth. And developed a first round of the intervention that was translated. And so this phase was a little bit switched with the administration phase. So we produced a manual that we then tested out with our target population, with our Colombian youth, to get more feedback. So we selected some different sessions and tested them out in what's referred to as theater testing sessions. That feedback was further integrated into the adapted manual. We engaged topical experts to review and provide feedback on the manual. And then we integrated this feedback into another draft, which we used to train facilitators, and then finally conduct a pre-pilot test, which provided further feedback from both quantitative and qualitative interviews that we could further incorporate into the adapted and translated manual. And so what were the results of this? So we developed a culturally adapted YRI manual, which our youth named Jóvenes Capybara. This name they selected because capybara, some of you might know this, but capybara is an animal that's known to be the friend to all other animals. So sort of represented the youth who were trained as facilitators and leading this intervention were the friend to all other youth, to all other animals. And some of the key adaptations that we made were obviously Spanish translation, but we reduced the number of sessions from 12 to 10. The youth told us that it was really just too long. Some things were repetitive, need to be more condensed, so that it just didn't take as long to go through all the sessions. We incorporated a number of culturally relevant metaphors that the youth helped us select. We reordered some sessions. So we found, based on the feedback, that sessions on trauma psychoeducation needed to go much later. And the youth wanted some skills and other types of things that would help them once they got to the trauma session. And also they wanted more mindfulness exercises. And so what's the progress that we've made on this trial to date? We have now piloted the Jóvenes Capybara intervention with a small group of Venezuelan youth once the program was integrated within an entrepreneurship training program. And this has been done in partnership with Rebel Business School. They've been amazing partners. They are located in other countries besides Colombia, but they're running an amazing program. And so we integrated Jóvenes Capybara within their 2-week entrepreneurship bootcamp. Feedback from this first pilot was then integrated into some additional revisions to the manual so that it would be applicable to both Venezuelan migrant youth and Colombian youth who had experienced forced displacement or whose families had. We've conducted a randomized controlled trial now of Jóvenes Capybara within this 10-day or 2-week Rebel program with our Venezuelan Colombian youth. And we've just now finished up our last wave of data collection. So we have data from baseline, post-intervention, and 6-month follow-up. So our next steps are really analyze the data. We're going to be convening some community advisory boards that we formed, and we want to start planning for dissemination and continue to meet with our stakeholders. So a key part of all of this work is really the stakeholder engagement through all phases of the process, from the beginning to the end, and then maintaining those relationships and partnerships. So what are the key takeaways that I would highlight? Again, stakeholder engagement at multiple levels of stakeholders at all stages of the research process can really help increase buy-in and sustainability of evidence-based mental health interventions. Integrating these interventions within alternative delivery settings is one way to try to increase the reach, and also the reach of other services like our entrepreneurship training program in Colombia. Using train the trainer models and training non-specialists or other types of community health workers or lay health workers can also help increase access within communities with low trust in other types of professionals or services. This can also help increase just or break down the barriers to access that are more related to potentially stigma or mistrust. And continuing to collect cost effectiveness data, return on investment data, other types of economic analysis and data can also help investments in from the government level or other stakeholders, NGOs, for these integrated services for vulnerable populations. And with that, I'd just like to recognize all of our amazing partners in Sierra Leone and Colombia. This include the University of Los Andes, Rebel Business School, and then in Sierra Leone, we have Innovations for Poverty Action, Caritas Freetown, and the Boston College School of Social Work is a partner in all this work as well. And so with that, I think we have plenty of time for Q&A, and I'll look forward to our discussion.
Let's all give Dr. DeRosiers a round of applause. That was excellent. I really enjoyed hearing about how your work has progressed since the last time I saw you present. We have some questions in the Q&A, and I also have a few questions as well. I want to again encourage everyone to send their questions in through the Q&A so we can engage in a discussion. One of our attendees has a question for you about long-term sustainability for the Sierra Leone project.
Yeah, this is a great question. And again, I'm going to go back to the stakeholder engagement piece. So what we're already trying to do right now is talk to Ministry of Education officials, talk to other actors that might be involved with donating money to the government there or supporting different types of services. We're engaging with the Teacher Service Commission. And so funding is always an issue. But what the actual cost of the intervention is not high once we've already trained teachers. And we also have a cohort. This is something I didn't really talk about in the seminar today, but we have trained over time through all of these projects, sort of like a seed team of YRI experts who are local people in Sierra Leone. And they have they've been trained in the YRI, they've delivered it, they've had supervision, and now they are qualified to train other people. So we've had this seed team that's trained all of our teachers. So one thing is developing the service delivery capacity. Hopefully through this work and through some of our data collection on fidelity and competency, we'll be able to identify some teachers as well through the phases of implementation who are just doing a really good job. Like they get it, they can be ambassadors. And part of it is identifying these champions, like who can really be a champion for this work. And so that's another strategy to really be developing the capacity in country, not relying on remote expertise and sort of identifying champions. So I think a lot of the implementation science strategies that might help sustainment, they might come into, we have to start thinking about them now and be planning for them to help support implementation and or sustainability. And then at the end of the day, I mean, there needs to be a lot of planning, but if the Ministry of Education is interested and we have good effects, if we have the teacher feedback is good, it doesn't cost a lot to deliver the intervention. It could also support, there are currently no guidance counselors in Sierra Leone. It could support the government or the Ministry of Education trying to invest in guidance counselors who could then, take this up, and it could be an intervention that they deliver in groups. So I think within schools, the possibility of sustainability is much higher. As long as youth are attending those schools. So of course, you're not getting or addressing the needs of out of school youth. So that is one limitation. But I think it's really just engaging with these partners and stakeholders from the beginning. That's the key.
Thanks. And you may not be at that stage yet in the work, but our colleague Arka Ghosh asks, how is the real world uptake beyond the research setting?
So I think that we aren't quite at that stage yet, but I think what this project in Sierra Leone should help us get closer to that, because the idea is like, I don't want to plan another research study on the YRI in Sierra Leone. I want to plan how everybody can continue it and how we're going to work with at all levels of these stakeholders to support uptake and adoption. And in other contexts, we're even earlier. So in Colombia, we're really just getting results from like our first RCT. So I think that is a little further ways out. but great question.
Thanks. Our colleague Mark Reinecke asks how you approach training of implementers in Sierra Leone, recruitment, qualifications, time to reach fidelity.
Yeah, good question. So with our teachers, we approached, and I mean, I don't think there's any like significantly right or wrong way to do this, but in Sierra Leone, we approached principals first and recruited the principals to enroll their schools, and then talked with the principals about teachers that they felt like were in good standing and might be interested. We've recruited an equal number of male and female teachers. To date, we haven't had people identify as non-binary or other identities, so it has been male and female. They've already, so that's really the only criteria that they are willing to do. They've been willing to do the training. They were interested in delivering the sessions and learning about this, and they would be committed to like the length of the project. In terms of how we went about training, so we had 12 CT members, these individuals who had already delivered YRI training before. Local Sierra Leoneans lead the training. And we had two groups of 80 teachers all in a room together. And the idea with training is that it's mostly, there's some didactic, so that, we have a YRI manual, they're looking over the manual, but it's a lot of role play and practice, role play and practice, role play and practice. And we have recorded sessions. It's pretty hard to do all video recording and then be able to upload with the bandwidth in Sierra Leone and download those videos, but we do have video recordings of role plays. We also have audio recordings, and we had a combination of people in person going through and using our fidelity and competency checklists to evaluate the role plays. So actually, in one of the slides I talked about booster training. I didn't actually go into that very much, but we identified any teachers who were just they weren't at the level of like 70 to 80% competency on the fidelity and competency checklists, and we've gone to the schools and provided booster sessions with them. So it's been a lot of work, but I think it's really what it has taken to train up to a level of competency that we feel like is we feel comfortable with and has the data behind it. So that's how, and the fidelity checklists are based on that we have session content that's part of the fidelity checklist. And then there's also more competency items like the group leader, facilitate discussion, encourage participation, manage disruptive behavior, assess risk of harm, things like that.
Thanks for that thorough.
Sure.
And we have an anonymous colleague who thanks you for your great presentation and was curious related to what you discussed about the Ministry of Education in Sierra Leone. They saw that your project in Colombia was implemented with support of the mayor's office in Bogota. Could you speak more about potential barriers or facilitators of receiving government buy-in in both of the settings?
Mm-hmm. I think it's been essential because when we talk about sustainability, it really needs to be like an evidence-based mental health intervention really needs to be integrated within an existing service to really support sustainability. So without the Ministry of Education support or the support of the Teacher Service Commission in Sierra Leone, we weren't going to be able to go into the schools. We had to have them on board. And at the end of the day, if we have buy-in from them, that is really going to be the best way to support sustainability. I mean, the barriers, I think honestly, sometimes there are communication gaps within the ministry. And so I think that has been one challenge where, maybe we'll engage with a few ministry officials and they don't communicate to other ones and no one kind of has a good, clear communication channel. And so sometimes it feels like we're backtracking in our messaging and communication because there are breakdowns within how the ministry officials are communicating or who's there, who's in charge. But I haven't seen yet. Issues with that. They've been really open and they want to collaborate. In Colombia, the Bogota mayor's office, there were more challenges. Again, I think it was essential. They played a large role in supporting our adaptation process. But right now, we haven't been able to identify, at least in Bogota, any services that are related to vocational training, entrepreneurship training, that the mayor's office itself is actually wanting to implement. Now, there are other like local governments in Medellin, they're doing a lot more with that. We're working on, developing relationships there. But the Bogota mayor's office had a lot of opinions about how we should be adapting the intervention, what types of activities we should include. And that was really challenging because some of them really didn't align with, let's say, what kind of activity you might do to illustrate mindfulness or practice it. And we would be left thinking like, I think we need to adjust that. But they were very, because they were providing the funding, they thought that they had more of a say. And so I think that there were a lot more challenges in that way. But the funding came directly from them. So I think that was part of also some of the challenges.
Thanks for that. I want to ask you a question, and I'm curious if you might share some pearls of wisdom around how an early career researcher interested in doing global implementation science work might get started.
Yeah, that's a great question. I think networking is definitely a key part. Just start talking to people who are already doing that work. Tell them you're interested. Pick their brain if you can about how they got started. And for me, it's also been really key to spend time in the places where I'm working. So that might not be possible for an early career person to actually just visit a context that they're interested in or that they see a need, that there's greater work from, but you can do some research about who's working there, and at the NGO level too, not just academia. There could be NGO and other types of community organizations that are really involved. And I think it's just starting to network and read and understand what's being done and where the gaps are. So that's I think what we're all trying to do to keep addressing these gaps.
Thanks. I also was curious, you did such an exceptional job describing the process that you use to ensure engagement and participatory approaches in your work. And I was wondering if you might be able to explicitly also talk about your philosophy and the values that kind of guide that work, as well as how you figure out how to balance prioritizing different voices across constituent groups, since sometimes one group may think that the intervention should be adapted this way, or another might think it needs to be different. So I think it'd be really helpful for our audience if you share a little bit of your thinking in that vein.
Yeah, sure. That's a great question. I mean, I think I'm very aware as I work and move in different contexts, especially in lower and middle income country contexts that have histories of colonization, that I am a white American female from a high income country. And I really actually just fundamentally believe that I'm not the expert. I have a lot of content knowledge and knowledge about different methodologies and research, and maybe and how that might be useful in these different types of settings. But I can't be the expert. So I think I really, from the beginning, have always listened. And if I didn't hear something, then I'm open to listening to it again, because I think we also all, sometimes things go by us or we mess up. And I think you have to be able to kind of learn from that and work through things. But I think just thinking from the beginning about, that we're not really the experts. I'm not the expert about what's going to work in another context. I bring certain knowledge, but I need to learn from everybody on the ground as well, like what they think is going to work and what they've tried before, and try to find like that common ground about how I can better support what they might want. So I think that's really key, and it's not always easy. And I think in terms of like different voices, or like thinking about the example of adapting an intervention, I think the most important thing is to retain sort of the core evidence-based content. of the things that we know work. So, so there's certain aspects of a cognitive behavioral therapy based intervention or motivational interviewing or PM plus or some of these WHO interventions that are sort of these active ingredients and core components that we know based on lots and lots of research in different contexts are really critical for achieving positive outcomes. And so we don't want to lose those, but how sessions can be delivered, by who, what's the pacing, how can we change examples, activities to be culturally relevant, orders, what context can they be implemented in? If you think about, I know David Chambers has the Adaptome framework, which is really lovely and helps kind of guide like a kind of a thinking about different levels of adaptation. But the idea is you're not going to compromise just those core things that you know are needed to potentially help people. I hope that answers the question well enough.
Absolutely does. Well, I like to give people like 2 minutes in between Zooms to run to the bathroom and take care of personal needs. There's one last question I'm going to pop to you and then we'll wrap up.
Okay.
An anonymous attendee asked if there's any opportunities for volunteering for college students, and then I'll wrap us up.
Maybe. There's my email there. Feel free to reach out.
Perfect. Well, thank you so much. It was such a delight to see your presentation. Thank you for sharing your expertise and co-created work, and look forward to seeing more of it in the future.
Thanks so much.